Thank you very much. Pleasure to be with you. Actually, I always pull out this anecdote when I get introduced, unfortunately, as a lawyer. The first major case I handled in legal practice, I used to work in litigation in Atlanta, was to sue the Medicaid program on behalf of the Medical Association of Georgia back in the mid-1970s. They were appalled at the thought that they'd actually have to sign a provider agreement in the beginning of what became a more regulated program. So we challenged it in court once upon a time and actually won a settlement. We basically ran an organized boycott for about a year before the federal government settled on it. But that was a long time ago. Medicaid's gone a long distance since then. The topic I was assigned for today is, let's see if we got this going here, how to achieve sustainable Medicaid reform. Reform of Medicaid in any form is an improvement. A free market version of it is a higher lift. A couple of years ago, though, I did write a chapter on this for a larger set of Medicaid reform proposals. I'll give you the product placement of it. It was a Mercatus volume called The Economics of Medicaid. Medicaid doesn't really know much about economics other than to hand out some money to different people in different ways, and occasionally it might trickle down to providing better health care to people. But what I'll do is the usual comfort level for talking about Medicaid is to first give you a little bit of a context and a overview, but I don't want to be too tedious with the usual numbers-driven type of approach. You can get different numbers if you want them. You got different sources. You can do different baseline years. So these are approximate directional trends is a better way to think about it than to argue that you've got tight precision behind all this. Even the Medicaid data not only comes with a lag, but sometimes the difference between what administrative data is and what might actually be going on. But we'll operate within the zones of possibility and probabilities. So Medicaid started back in 1965, the secondary product of the Medicare authorization and expansion. And Medicaid got off to a little slower start, but certainly began to ramp up and grow further. The big growth period probably was the late 1980s and the early 1990s to what we've seen in the last 5 years, another surge of growth. That was mostly courtesy of some congressional actions by Henry Waxman and began bringing on other populations and other types of services and other requirements that accounted for a sizable expansion in where it started. And so Medicaid basically was already large before the Affordable Care Act, and now post-Affordable Care Act, it's really huge and getting bigger all the time as our largest health care program. On that front, Medicare, you can get different numbers on this one. One number that House Energy and Commerce put out in the recent overview was 72 million. That's over the course of a year, not people being on the entire year. You can get a different number for 2015 of the average monthly enrollment because there's a bit of a transition to get around 66, 67 million. And again, it's in the zone where it's gone way past the size of Medicare. It has become our most dominant collective health care program. Most of Medicaid, there are some exceptions to this, is income-based as opposed to condition-based. The income limits have varied over time based on state decisions and also some federal action for different types of populations. In terms of how much we spend on Medicaid, one measure by the actuaries at Centers for Medicare and Medicaid Services would be about $496 billion that's calendar year 2014, and that's about 16% of what we're spending overall on health care, and it's growing. The other main characteristics of Medicaid as a program, it's said to be a federal and state partnership. Each side wants to take advantage of the other, but that means there's split funding on it. There are different formulas, and that tends to draw a lot of attention in terms of how much is kicked in by the federal government versus state governments, usually based upon loosely per capita income in the states, but there are ways in which those matching payments are exploited through the states pretending to be putting up money that they're not really, as well as some of the larger and not necessarily poor states having the latitude to expand their programs more and pull down more dollars overall and more extensive services than necessarily the poorer states you would think would get it. A different way to look at Medicaid is let me go back there for a second. I just skipped over the previous one. Who's enrolled, and this is the standard way. Maybe I missed that one there. Let's see there. Okay, hold on. There it is. the enrollment share of who's on Medicaid. When you look at this, you see a different mix in terms of. I'm missing. The reason I'm hesitating here is this is the spending side, and there should be one here that says the enrollment. Maybe they got reversed. Let me just go back to that a second. There we are. For whatever reason, they're in the reverse order of what I intended to do. So most of the beneficiaries on Medicaid in the more modern era of the last decade, and this is just the CBOs Baseline for 2015, a very high share are children. That reflects the CHIP expansion in 1997, which a lot of it went into Medicaid. And, the old tradition of Medicaid was coming out of the welfare environment, which changed in the mid-1990s, but that basically was the old AFDC populations, women with children being eligible for Medicaid. When you combine that with CHIP, you can see kind of in terms of who's actually on the rolls, a sizable number are, that's basically below 18. Non-disabled adults has been a expansion population, particularly in the last 5 years. Didn't used to be quite that number. They're not just mothers there, but that's now 31% of the beneficiaries. And a much smaller share are the blind and disabled. That's mostly disabled, 13%. And the elderly, these are the lower income folks who are already on Medicare. They're usually called dual eligibles, but because of being lower income, they get supplemental services through Medicaid. There's also some coordination problems between the two programs. So that accounts only for 8%. And the reason I show you that first, which is, okay, that's where the bodies are, and that's who's being enrolled and what seems to draw the attention. But when you look back at where the actual, I'm getting here, the spending side, you see the children are pretty cheap to insure. So they only take about 20% of the dollars, and the non-disabled adults kind of a wash, but about 28%. And then you see how costly the disabled population is. We don't talk about that much when we talk about Medicaid. It's all about, let's get more folks onto the rolls, let's cover them, poor people. But it turns out that the disabled population is really where the real costs are. And the elderly, to an extent, more costly than their share of the enrollees at 16%. A different way to look at that is look at past the enrollment is the actual, if you will, cost per category or head. And that just reinforces the point in terms of what the average cost is within that broader category. Of course, there are going to be variations in subcategories within that, but you see it's pretty inexpensive to enroll a child on the Medicaid program. Non-disabled adults also generally going to be fairly healthy, but low income. They don't cost as much, whereas the big costs that are sunk per capita are in the blind and disabled and the elderly. So that's how you might cut it up, which that drives a lot of what you end up seeing happen in the Medicaid program. But we'll take a quick detour to talk about why Medicaid is able to cover so many people, because it doesn't pay very much for the care to treat them. And that's mostly reflected, although there's sometimes curbs in terms of services in reality as opposed to what you're theoretically eligible for, is it pays much less to, in the future, folks like you who might be treating Medicaid patients. Medicare also doesn't pay as much as private insurance does, as you see there, but it's that underpayment which also then is reflected in the access to physicians. If it's, in effect, a more than a loss leader to treat a Medicaid enrollee, on the margins, it's going to be harder to find an accessible doctor, and certainly a higher quality doctor for a good bit of that population, even though some folks will go out of their way to try to do that. Economics has a pretty strong effect in that regard. The bigger hit probably happening on the hospital side for both programs. Medicare a little bit more generous to physicians in a relative sense. So let's talk a little bit about the Affordable Care Act. It launched a major expansion of the Medicaid program on several dimensions. First, it was trying to mandate this, thought it was everybody was just basically going to have to join in, either willingly or not. before we had some legal battles over it. It raised the income thresholds. A lot of states were not very generous at all in terms of the level at which they had options to make people eligible for Medicaid, particularly the southern states. You can get some really low numbers as a percentage of poverty pre-ACA. So what the Affordable Care Act was saying, we're going to set a floor that basically was going to be with the newer populations that became eligible as opposed to old Medicaid, but this is all a transformation after the court decision. It was going to be as much as 138% of federal poverty were going to be enrolled in the new version of Medicaid. And there was also going to be a much more generous share of the funding for those newly enrolled populations, the people who were previously eligible, that initially was going to be 100% paid by the federal government. All the taxpayers actually are also state taxpayers, but we'll pretend they're in other states, and so it was free money. That would eventually, over several years, once this kicked in 2014, move down to 90% share over several years. We're almost about up there right now. And what this really operated as was the new populations for a state would be cheaper to cover. Almost all the money is being paid by the federal government. So what's the problem with adding more of the new folks? We may create some disincentives with regard to how you treated the older enrollees who are already eligible under your program. So the main target there, not exclusively, were in many states the general term is able-bodied adults without children. Were not being covered by the program at all, or if they were at extremely low income level. That accounted for the predominant amount share of the expansion population, although there were also states where by raising their income eligibility thresholds, you also brought in other folks who were previously not eligible for Medicaid. Now, after the Affordable Care Act did these wonders and brought everybody onto the rolls, it still didn't solve a lot of other problems that we still have with Medicaid. Quality of care has been a serious concern, remains a serious concern, and accessibility of care. The quality side, there's a number of studies. Now, you can, argue the angels on the head of a pin and try to parse them and say, well, you haven't adjusted for every single factor. But there's enough academic literature to show that the care that Medicaid beneficiaries receive in general is not real good for their health, particularly certainly compared to private insurance. But in a number of cases, it even gets close to making you wonder whether you're doing much better than being uninsured. I don't want to say that absolutely, because there are ways to argue about that on the margins. But it suggests the very disturbing level of baseline Medicaid care as a general rule. That reflects both lack of funds and sometimes overreaching in terms of trying to do too much with too little. Accessibility care is also based upon simply just because everybody's covered and theoretically you should be able to find a doctor, you may not be able to get one who will treat you in the time you want to. There's also the larger concerns which haven't gone away of the longer term fiscal consequences, the overall both debt burden, budgetary expense. That was real before the Affordable Care Act passed. It's gotten compounded by the magnitude and scale which we are funneling so much of our healthcare system through public dollars, which tend to not go as far as they might and have other consequences when you try to either run deficits or raise taxes to pay for it. The other thing I referred to before is the tendency for, if you're a state policymaker or administrator, to say, well, these folks who are newly eligible under the ACA sure are a much more attractive population for us to get involved in because they're not costing us any money than the old folks who are lower income or fell into more disabled categories. And that kind of creates a split incentive between, do you just want to have more volume of who you're covering as a political figure, or actually doing a better job of caring for those who are most in need. The other sets of continuing problems, we already had a substantial amount of folks on public programs, and now we're rather aggressively expanding, if you will, dependency on entitlements on a longer-term basis and all the consequences of that. There are also concerns about crowd out when you make people eligible for publicly funded programs on the margins, and you can argue on the magnitudes of this. There have been a number of different studies. It tends to crowd out private alternatives or private insurance coverage, which coverage previously existed, whether it's employment-based or individual. You get a substitution of that, and not necessarily better quality, but you in effect drive some private funds out of the system. You also divert the priorities and the spending patterns of state policymakers and budgeteers, which is if there's cheap money to spend it over on Medicaid, which is going to largely be leveraged with federal funding, you will spend more on that compared to what might be some other competing priorities in state budgets. Or if your share of state spending has gone up for Medicaid, which happened under the traditional program even before the ACA, then you start having to economize on luxury items like state funding for education and other types of infrastructure. That on the margins, the states are squeezed, particularly in the period of the recent recession, and so we see less of their funds being available for what might be other important public needs than just Medicaid and health care coverage. And in the Medicaid program, in a systematic sense, because of how it's tended to be operated, you have a lot of problems in transitions and handoffs. People go on and off the rolls. Medicaid care itself, not the most tightly integrated and coordinated, with some exceptions. And so we have problems in terms of breakdowns in the way the system operates. Now, here are, I see what I did. Okay. So what are the standard policy approaches that focus on, I'll say this loosely, the right of center, not necessarily Republicans, conservative, free market? That's the general category. What tends to be in the toolkit, in the basket, for what they talk about when they say Medicaid reform? Perhaps sustainable, perhaps not. A lot of focus on the matching payments and the percentages that the federal government kicks in relative to the states. And the argument is that this, the FMAP stands for Federal Matching Assistance Percentage, that this creates some serious disincentives in terms of how states view the Medicaid program, that they will overspend because it's not all their money, and without some type of fixed budget to assess the quality and value of what they're doing, they'll tend to overshoot the mark. So there are reactions to that in terms of policy proposals, but that draws a lot of attention, whether it's to cap the federal assistance, to index it in a different manner than the rate of healthcare spending in the future, or to simply make it a flat amount and then let the states decide what they want to do beyond that. Those are all variations on the standard approach, which is very much as much budget-driven as certainly as it would be, well, what are we actually doing in terms of the care we're delivering? That's less of a focus on that front. There's also many pushes to try to delegate this issue to the states. The argument being the program is very rigid, bureaucratic, less flexible in Washington, trying to govern the complexities of differences in care and populations at the state level. So let's get it out of here and get it back to the states and give them more flexibility. And that tends to drive whether they're block grants or other types of capped funding proposals. There's also a little bit of a political element to it, which is in the recent context. Most of those states are run by similar-minded policy people, Republicans, conservatives, or whatever, and so let's have them do it rather than Washington do it. There's not always a clear-cut view as to what they do any better, but at least we'd get it off the plate of folks in Washington. Now, there are limits on the block grant approach. You can draw these things out on a spreadsheet or in legislation. It looks like you've solved your fiscal problem. You know, we got all the payments controlled. It's predictable environment. Underneath the surface, though, there are going to be pressures and tensions that build up after year one or year two. And all of a sudden, what looked like a nice little formula to solve a budgetary problem may leave a medical mess behind. So they may not be as sustainable as they look, aside from the standard political food fights over how much do we get in my state as opposed to your state, and whether the historical formulas should hold forward going into the future. The other impulses in the standard public policy options from conservatives or free market types is to try to at least put a private market face on what is largely a state-run bureaucratic healthcare program. And so there are variations. Well, we'll make it a little bit more like private insurance. We've already had a lot of managed care through private insurers come into state programs, more so in the non-disabled population, although it's made some inroads there in recent years. And the idea is that we'll just somewhat merge it budget that'll be like private insurance and almost as good as private insurance, whether through waivers or through other types of expansions that enlist private insurers to manage what otherwise really can't be run as a top-down program, even from state ranks alone. And there are also efforts to create some mini incentives which make everybody feel good about beneficiary being a little bit more responsible for what otherwise is just a check written by the government or guarantee to care. And you see things there such as at least modest approaches to, in some extent, increased cost sharing, although there are pretty tight limits on how far you can go on that front in most cases. Paying at least a tiny share of the premium, so you're a little bit more invested in your health insurance coverage as opposed to simply here is it was what was given to you. And in the more grander versions of this, there are the ambitions to mainstream at least the working poor, or the could-be working poor, that they would have an opportunity to get health insurance as good as everybody else. And that means that, in essence, you'd get at least exchange-like coverage delivered through private means rather than more traditional Medicaid. There are, again, limits in this I'll get to later on that actually making the numbers work on that are perhaps not as easy as are said to be. So that's kind of the standard toolkit, and you've probably heard this periodically, and it leaves you a little bit saying, is that kind of about all you got? You solved a budget problem, but you haven't really talked to me very much about what's being done on the ground. Healthcare, are people's lives being better? Does this program operate, in a different way than it did before, other than it looks like it's a little cleaner in a fiscal sense, and we've buried the problems by handing them back out to the states. The problem with that type of discussion is Medicaid, although there's a great impulse for this politically, is not just a numbers game. It's not just a matter of making budgets work out a certain way or hitting coverage targets and goals and say, look how many people we covered. We don't know what we're doing with them, but they're covered by something. The other thing is that the real problem, if you're looking at the fiscal side or the budgetary side of Medicaid, is it's not really that costly per person, per capita, even in the different categories. That's not where the spending growth is coming from. And you can, torture the numbers in recent years. The budget for Medicaid is going up substantially, but it's mostly because they're putting a lot more people on the Medicaid rolls. The per capita cost for them compared to growth in other per capita costs for whether it's private insurance or Medicare is just not at the same growth rate. So we do it very much on the cheap. We're just doing a lot more of it on the cheap in Medicaid. The alternative to this, of course, which would appall political types who have wanted to claim credit for this, is to actually do a better job of delivering better care to the people who need it the most. Now that's harder exercise. You don't get as much credit for it, but it also means you have to better target the most significant subpopulations who need deeper, serious interventions as opposed to the lowest cost physician you can find in order to cover more people who are moderately healthy but are otherwise low income. A reach beyond that is to get out of the medicalization alone, to say that that's all the problems that are facing poor Americans, and to think about what would improve their lives overall, as well as their health, in terms of other types of, and they very well may be public governmental investments in rebuilding or starting to build the human capital, their health capital, so that they actually have more intact, positive lives going forward, and reduce the future claims they will be bringing into the healthcare system. Now, everybody's going to get sick eventually, but eventually covers a wide range of variation, to the extent that people are healthier longer before they succumb to particular illnesses. You're much better off ahead of the game if you look at it on kind of a longitudinal basis. So that's trying to change the way in which we think about whether we're helping people or whether we're just helping a system, propping up some hospitals that have low-income patients to pay them a little bit more, but not necessarily changing the lives of the folks who are said to be the beneficiaries. Now, a different way to restructure block grants and fiscal formulas is to make them a little bit less simplistic. they should be a means, but not an end in themselves, as I've said, on the budgetary front. There should be some higher ends behind it, as opposed to just the usual political dynamic, because those proposals have been around for decades and eventually run aground. So if they're thought of as just a beginning, you'd want to build in some adjustments in what is the first cut of any type of fiscal caps or block grants. One adjustment, more recently getting a bit of traction, is to at least recognize you've got different parts of the Medicaid program, different populations who cost different amounts. So if you're going to do this on a allotted basis, you have to recognize that as a simple version, disabled Medicaid beneficiaries cost a lot more. They should not be under the same type of per capita cap as low-income adults are. Different expenses, different categories. You may or may not want to make a different category of per capita caps for the dual eligible, low-income elderly. But again, it's a different category, and it's really almost a different program, even though we all call it Medicaid. If you treat everybody the same as we've learned elsewhere in the healthcare system, you just get a lot of different results buried underneath what seems to be a simple fiscal formula. The other element, which is promising but often falls through, is to think about setting some broader guidelines and priorities or commitments to achieve measurable outcomes, but allow the actors the flexibility to find out how to get there. We really can't manage healthcare from on high, and sometimes we can't even manage it from within a state. But if you get a pre-commitment to say, here's the standards by which you're going to be measured, can you do this? You'll be rewarded more if you achieve it. You'll have some risk if you don't, not just in the crude capitation manner, which is another variant on that. That type of negotiation between state officials and the federal government to say, yeah, we'll take on this obligation, and it's pretty transparent as to what we think is important and why we want the flexibility to do it, and we're going to be accountable for the federal dollars that we received as to whether or not we meet that or not, and try to simplify it so it's only a relative handful of accountable, transparent measures, as opposed to simply we shoveled out more money and we've done our job and we're going home, but we don't know what we actually produced from it. An even further stretch on this front would be to take the middleman out of it even more so. If people are poor, their problem is they're poor. They may have some healthcare needs, but perhaps we can get them more engaged in truly being empowered in part of the decision-making process. It's been to a limited extent in things like cash and counseling for durable medical equipment in aspects of the Medicaid program, with assistance, with information, with financial support, and with some accountable medical team around them. Why do we have to filter this through the intermediaries of the bureaucracy and politics? That would be more of a true consumer empowerment, where you're actually providing the assistance more directly to the beneficiaries who are said to be in need of it, and allowing them to have more of a voice and choice as to what it means to them. Now, you can carry this too far. Different people need different levels of assistance, but it stretches beyond just passing the resources from one level of federal bureaucracy to another level of state bureaucracy, and thinking you've really accomplished a lot different than that. I sometimes think of this in terms of the evolution. Somehow, if we just let the states do it and state politicians do it, they'll do it differently than the federal governments do. This is basically a quick exercise in biology, which is to say that I often think of state policymakers and politicians as mice studying to become rats. They just don't have large enough market share, but the DNA is very similar in terms of being involved in the political exercise. And so the idea that simply because they're in a state capital, they operate differently than folks in Washington, they're just practicing to get up to the big leagues. But if you give them more latitude, they're going to be politically driven rather than somehow so sensitive to the slightest signals from the grassroots that they would never, in effect, do anything but carry out the wishes of those they're supposedly enlisted to support. Maybe that's just my view of the political biology behind this, but I think I've got some history on my side. The other thing is not to, as I alluded to before, not overpromise. we get grand, and this is what you do in political and even think tanks, saying, we can do this, it's going to be wonderful, we're going to kind of give you some tax credits, and you're going to be just like those other folks who've been working all the time and, making better incomes, and we want to make sure you're all going to get, health care just as good as a member of Congress or the folks who are otherwise subsidized. And that's a nice, story. But when you actually start figuring out what it costs and how our system operates, it falls a little short. The reason why the Affordable Care Act was structured the way it did, under a lot of political complications was trying to go through, was to make it look like it didn't cost any more than what they said they could find money for. And in order to fit within those parameters, they said, if we're going to cover all these people, we're going to have to cover them at a lower cost. So let's put more of them in Medicaid than into private insurance, because they ran the numbers, and these are always estimates, and they can change a little bit over time. One older estimate by the Congressional Budget Office was someone goes on the private exchanges, or the public exchanges, with private insurance, we think we're taking all-in costs of subsidies and everything. It might be about $9,000. That was one estimate. Put them on Medicaid, it's $6,000. Do you ever wonder why the expansion has tended to be putting more people on Medicaid? Because it costs less to the government to enroll people. And why do they cost less on Medicaid? Is it because it's a more miraculous, efficient program? No, it's because they pay doctors and hospitals less, most of all. And the networks are more narrow, and that even more so when you move that over to comparable private insurance for someone who's working full-time at a reasonable company, which is providing a good health benefits plan. I'm just suggesting that although we need to be compassionate and sensitive to people who really need help and can't help themselves, that if you start saying everybody's going to start off at the Lake Wobegon level, not only can we not afford it, but you create other types of collisions and disincentives in terms of why do you want to aspire to have a higher income? Why do you want to aspire to work more hours if everything is kind of the baseline guarantee gets higher and higher? So that's the limit on trying to be able to fit more people into a more expensive promise and actually make it come about. And instead, we weasel out on the deal, and you end up with the type of wide and thin Medicaid coverage you receive instead. The other variation on this is certainly there's a cohort, a component of people who are on Medicaid. They're not going to get better for a long time. It's going to require a lot of work. They need some, coordinated intensive care, a lot of treatment, and we should not shirk our responsibilities to do that. There are other folks, though, who are in, relatively short-term or should be short-term economic straits. They might need, some targeted assistance for a limited period of time. We have trouble doing that, though. We were able to cut people off on welfare rolls, perhaps, but it's a little more difficult when you start talking about health insurance coverage. But the idea of distinguishing among the low-income population for folks who need a short-term help when they're flat on their back, lost a job, other types of breakdowns within family structures. That's real, but it does not mean you're signed up for 2, 5, 10 years as long as you feel like it. And we need to think about that type of distinction and drawing some of those lines in better sorting out where our priority targets are for scarce dollars. The other part of this is that low-income Americans have some other needs too. A lot of folks are moderately healthy or will be okay. And their highest priority in life may not be to see the doctor 3 times a year as opposed to every other year. Or other ways in which they need better schools, better job opportunities, other types of public investments in their lives which will make their trajectory better and more promising and on a longer-term future. And we should not move away from assisting lower income, vulnerable Americans, but we should think about what actually helps them, what they need the most. It's imprecise because you can always argue these on different ways. The Medicaid study done a couple of years ago and another iteration of it in Oregon, showing that after you do an expansion for folks who go on to Medicaid, maybe they get a little bit more protection against income risk, but essentially their health hadn't changed a whole lot. But on the other hand, assisting a family that's breaking down before kids are even going to school, intervening on the ground in that, providing safer neighborhoods, other opportunities to find employment, early childhood interventions, an educational system that actually works. That might actually deliver a better life ahead for many poor Americans, a future they can look forward to climb up the ladder, social mobility, and also improve their health than what we think we're doing with kind of basically smothering them with thin and wide healthcare services. So that's part of my general question on this from our blind spot in thinking about medicalizing and subsidizing services for folks who are low income and not seeing beyond that as to what else we might need to do if we actually wanted to have a functioning Medicaid program which did its job better, but on perhaps a more narrow scale, while thinking about what else we need to do, which we haven't been doing very well, to improve the lives of younger and poorer Americans. On this front also, improving healthcare delivery is something that we tend to tune out a little bit on the right of center side. There's a wide range of items there. Managed care can be a cliche because everybody's in managed care, but it doesn't really mean it delivers much more than kind of a lot of redundancies and administrative costs. It's the execution, not the sloganeering that matters in terms of how you carry this out. There's a standard formula: keep people out of the hospital, give them the necessary drugs they need at an earlier stage. Find ways to keep them out of the emergency room, coordinate the handoffs and care. We know that in concept, but actually some programs do it and some don't. We need to pay more attention to that than just simply what it looks like on paper. Measuring, assessing, engaging, and rewarding the care that's actually delivered is talked about, but not often executed very well. So we need to do more for fewer people with a little bit less money. And as I said, there's a broader range of things that we need to think about to assist the lives of the vulnerable. To free up the Medicaid funds doesn't mean they go away. That means they need to go somewhere else and repurpose for broader and better investments. And also starting younger. Pays off a lot more than catching up late. Our healthcare system is very good at patching up the problems that have been left behind, just like the educational system does, as opposed to starting an earlier stage so they don't develop as quickly. But with that, I think I'll shortcut on my usual what's your big plan, because we can stop on that front. I'll take some questions.
During the break, so those people who need a mental break can get it. So, what? I did, if that's okay. Go, Mary. You haven't asked a question.
Oh, thank you. Yeah, I'm trying to absorb everything that you're sharing because I'm a bit of a layman with all this. But one of the things that really caught my attention was when you mentioned the whole concept of crowd outs. Can you just expand on that quickly, just so I get a better idea?
The crowd out usually starts with, if you have public insurance, you start to have private sources of insurance begin to erode and disappear. That probably got billboarded mostly with the Children's Health Insurance Program, where, oh, look, all the wonderful things we're doing for the kids, and it turned out there was some previous levels of private coverage which began to be reduced. There's studies on it which can argue different degrees of it, but that's a standard welfare issue. Sometimes in economic terms, it's called the substitution versus the income effect. If you have a higher income, you don't have to do things to get to that income level you targeted, and therefore you work less or do less of other things. But there is a significant issue on the margins for substituting public money and public mechanism, which may not necessarily be as good, but close enough to good that people don't find ways to pay a little bit more on their own or explore other alternatives, or those who were previously financing them say, I can outsource this to a publicly funded alternative. And we end up losing what we had, and then we end up poorer for it in the final balance.